Hello, good morning, good afternoon, everybody. I'm Isabel Lusada, the CEO and founder of the Amyloidosis Research Consortium. And I'm delighted to welcome you here today for one of our Art Talks webinar series. And today's topic is on navigating care choices at the end of life. We have two impressive speakers joining us. Rebecca Kirch, who is the Executive Vice President of Policy and Programs for the National Patient Advocate Foundation, based in Washington, D.C. And in this role, she brings patient and caregivers' voices and insights to the table in health reform efforts. As a leading health policy expert and advocate in her field, Rebecca is dedicated to advancing person-centered policies and practices that really put patients at the center of healthcare. Jill will be speaking as well, and is a board-certified I'm going to have a little trouble saying this, gerontology and cardiology nurse practitioner who's worked in the field of cardiology for 20 years and has worked directly with amyloidosis patients for the last 8 years. She is based in Utah's Health Cardiovascular Center as a nurse practitioner and has been there since 2009. She really enjoys helping patients improve their quality of life and has worked part-time for a local home health and hospice company offering home-based palliative provider care visits to late-stage heart failure patients. So just by way of introduction, the Amyloidosis Research Consortium was founded in 2015 and is really dedicated to advancing the science and understanding of amyloidosis and making a significant contribution towards the curability of the disease. We have 4 main areas that we work and focus on. One is improving the speed and accuracy of diagnosis. We have 2 columns of science, understanding the genetics, biology, and natural history of the diseases, and also accelerating regulatory approval and reimbursement for effective treatments to make sure that we get drugs developed faster into patients sooner. And we also work on enhancing the care and quality of life of patients and caregivers throughout their amyloidosis journey. This is really important for us and can make a huge difference to impacting how patients experience the disease and their caregivers. I would like to just thank our sponsors for today. And before I hand over, just a couple of notes. There is a question and answer box. We'll have time for questions at the end of the session. And so put your questions in as they come up, and then we'll go to moderated questions with both speakers. At the end of the meeting, we'd love for you to take, we'll share a link for a post-webinar survey, which just helps inform and shape our programs. So without further ado, I'm going to hand over to Rebecca to start. I think we have, Jill's just having a little technical issues logging in, so hopefully she'll be on in a moment to join us. So Rebecca, thank you.
Thank you very much. And I'll move to share my screen. Good morning and good afternoon to everyone as well. I'm Rebecca Kirch, and I'm all those things that Isabel described in terms of the background that she shared about policy and practice change being sort of my professional life. But I'm one of you in my personal life because I've been a care partner to many in my family, including my husband, who has complex chronic illness. And I chose this title slide photograph, which I took myself in the window box of our treehouse, this sweet little bird, because I've so often felt this vulnerable in encountering what's become sort of a frequent flyer experience of the health system for me, but in the beginning it wasn't. And even still and now, going between hospital, ICU, other experiences that I've had to face with my husband, I've learned the importance of sort of this mantra for our family. And I want to share with you because I hope this resonates for our audience here. In communicating with our healthcare team, the lived experience, expertise that we all have is so vitally important to contribute to conversations, because what matters to us is as important as what's the matter with us. And that can get lost in the healthcare system. So we really wanted to dive in with that in this discussion today. Because what I found, and this is my husband, Eric, with our son, Henrik, probably about 6 or 7 years ago. Henrik was 10 when my husband first fell ill with a neurological condition we've never really been able to figure out. But what I've seen over the course of our experience is that as soon as you get wrapped up with a serious illness diagnosis, like amyloidosis, we get conditioned to talk only about our condition and not the life circumstances surrounding our condition. But it's always on our mind. It's just sort of left out of the clinic walls when conversations happen. But let's not do that anymore. It's really important, I feel, that we consider the opportunities we all have to flip that script and remind the healthcare practitioners who are taking care of us, remind each other that we have to focus on us as people beyond our disease. That's critically important in order to sort of get the best high quality care possible. There's Jill. Welcome, Jill. We're so glad you're here. We literally flipped the script because I'm going first. Jill was supposed to be first, but we'll dive in with me and then move on to Jill's piece. So this is now my husband and son, grown up quite a bit, newly experienced for us wheelchair entering our lives, and more inviting our dog, Dylan, who is the love of our lives and probably the best medicine we could imagine. I say this to say that that person beyond the disease involves so many others in our community, in our lives, that the healthcare system really wants to know those connections, even though they're not conditioned to ask about them. It's so important to help support decision-making that we all do to put people at the heart of healthcare. And what I've observed, both in my life helping patients and families who typically are feeling at their most vulnerable, is, treatments only work when they work for you, based on what you feel matters most. And it's so essential to know, even if you fail like that naked baby bird sometimes in the unfamiliar setting of hospitals or clinic offices, that you always and must have a say in your care. That's the only way that everybody can get it right. And it's essential to insist that your practitioners listen, not that just we listen to them, but that they listen to us. Conversation goes both ways, especially in the context of healthcare. And feeling heard and understood is actually a new quality measure that practitioners in palliative care are having to be held accountable for, that their patients will report on whether or not they felt heard and understood. That old saying about people remember more how you made them feel than what you may have said. That's just so often so true. And we've captured that in a patient-driven quality measure to say, feeling heard and understood is as important to me as the way that I'm treated for my disease. That's what builds the trust and confidence that we all want to feel for ourselves, for our loved ones. And that's sort of the fundamental core of having conversations that are meaningful, productive, and comforting. So I've included on this slide, and I'll love to hear in the Q&A your thoughts for improving it or adding to it. What are the things that we really want to look for in a practitioner that help us to feel heard and understood in making decisions across the course of disease, from the very get-go on through whatever the trajectory may bring, and including as the end of life may draw near. And top billing is listening to the patient and acknowledging emotions. Don't just rattle off facts if you're a practitioner. We need to give time and a pause to let people express how they're feeling and practice empathic medicine. We're looking for that as patients, as caregivers, someone who can connect with us and be empathic and understand, this is hard, I'm here with you. Learning about what patients and families understand about their illness and how they like to hear information. Some people are very fact-based, others want metaphors or want to know just the very high level stuff versus the details. Everyone has a different way of ingesting information, and it's important for the healthcare practitioners that are caring for us to consider and ask about, how do you like to learn? Recognizing that what we bring to the table or bring to the clinic room in the conversation is as important as the medical knowledge, the scientific knowledge that the care team brings. Those two work together to deliver quality care at every stage of illness. And finding that time and space. This is a precious commodity today where practitioners are forced to see so many patients in a clinic in a revolving door. But that conversation, focusing on the patient as a person, not as a body part or a constellation of symptoms, that's something we're all looking for and wanting to feel heard and understood. And inviting those who are helping support our care, family members, partners, friends, who may accompany to visits, or especially those who don't necessarily have that caregiving support on hand. It's especially important to hear about the concerns that you have as a patient or that your caregivers do, and how those needs can be supported through an illness journey. And also making sure that we all get the tools, get steered to what we need to have effective conversations, as I'm describing, that help give the scaffolding for all of us to sort of sort through, what does it mean to go through this disease? What are the decisions I'm going to need to make? What do I need to think about beyond just the disease in terms of my life to keep things rolling along? There are tools available, and I'm going to feature them in this talk to get us started. But where I'll start, just as a reminder for all of us to know, is that the more we speak up, the better healthcare can be. Being a shy violet in the context of any kind of disease is not a helpful position to be, because you risk losing that say in the care that you get. You risk losing the connection with your healthcare team. And what you gain is the opportunity to preserve quality of life, make that a focus of care no matter what the prognosis looks like. And that means talking about what matters to you and telling the people that matter to you, so that everybody's on the same page and understanding, where am I coming from in terms of how I want to experience this illness? Nobody wants to be sick, but if we are, let's at least talk about what makes us feel better, whether or not we can get better. And let's tell the people who may be important to us in terms of making sure that our wishes, our preferences are honored. So in palliative care, which Jill's going to dive into more specifically, one of the key things in what we say is the syringe of palliative care is the communication skills that doctors, nurses, social workers that practice palliative care alongside disease-directed treatment contribute to help support conversation around what matters to you. And I've included just a few of the types of prompts that you might expect to hear from a palliative care practitioner, even if you don't from your disease-focused specialist, whether it's your cardiologist or otherwise. We're trying to get everybody to get conversant in talking about these things, but palliative care is really darn good at it and working to extend these skills to other specialties. Talking about patients as people, asking about how did they like to get their medical information, and what's your understanding of your situation right now, hearing about what's important to you, what you're hoping for and your worries, and where do you find your strength and comfort. This is the stuff that's outside what I said about, everybody's conditioned to talk about their condition. When you get in a clinic room, it usually dives right into symptoms or concerns about the disease itself, even though swirling in our heads as well at the same time are some of these things. Both are relevant for thinking about care and care planning. And why is it so important to plan ahead? Because nobody's at their best when they're feeling at their worst. It's certainly better to sort of think about and talk about these elements of life and living that matter to you when you're feeling as strong as possible, when you have people around who are feeling as strong as possible outside the context of distress that may come later. So to get the preferences and the priorities that you hold dear front and center in the medical record and in practice for taking care of you, it's really important to talk about these things with your loved ones, with your healthcare team, and doing it from the context of what gives my life meaning to me? What is it that gets me up in the morning and makes me lose track of time? And how can I make decisions and have support from my healthcare team to make sure that those elements of my quality of life are priorities for them and priorities for the decision-making that we partner in together? That helps take away the stress that may otherwise emerge if we start to get symptoms that are less able to be controlled. We've already done some of this homework up front to understand what it is that we need. This kind of planning helps if you take the time to identify who can be your backup person to help support you and know about what you would want if you're not able to make decisions for yourself. It's really important to be thinking about these types of opportunities, and there are tools I'm going to feature for you that sort of take you through the steps about who would be a good person to think about to help be your backup person, to help convey your wishes should you not be able to. And also just to be able to bat around ideas with others so that people are clear, your team at home or elsewhere is clear with what really matters to you. There's also the opportunity to document and even legalize, formalize, if you will, what your wishes are, and the people have your proxy that are really important aspects of planning for care, just so that you kind of get everything straight and up front. It's hard to think about, but it's important. And just because it's hard doesn't mean we don't, as patients and caregivers. Think about what my mother would have said. She had ALS, which is a very difficult disease. And she said, I just want to know what it's going to be like when the other shoe drops. I feel well now, but this is a disease that does deteriorate my body, not my mind, but my body and my ability to speak. So I want to know the kinds of decisions I should anticipate having to be made by me or by my backup person. And it can involve things like the type of care you want and where you want it. Do you want to try to remain at home? Would you be more comfortable in a hospital? Everybody will have a different answer there. We can't let the healthcare system make those decisions for us or make presumptions about it, or the medications, tests, procedures, and things that we're willing to confront or not, let alone when we get toward difficult decisions that often accompany end-of-life decision-making around whether or not to pursue different versions of life support listed here, whether it's CPR, having ventilator or breathing help, dialysis, transfusions, a feeding tube. All of these things have impact on quality of life, especially at the end of life. And it's just helpful and comforting actually to face these hard bits of facts ahead of time so you can know when the other shoe may drop, what you might expect, and how you can pre-plan, and you can change your plans along the way. There's nothing that holds any of your planning in stone, but it just gives comfort to be able to game out a bit what could lie ahead for yourself and your loved ones, and how you can sort of pre-plan and anticipate some of the harder decisions using tools that are available. So I want to feature in my last few minutes of speaking some of the tools that I've found tremendously helpful in any kind of disease diagnosis and any kind of care setting that you may find yourself in, whether it's at home or in a nursing home or in and out of the hospital. There are tools that have been designed with patients helping drive what's in them. And one of my favorites is Prepare for Your Care. It's an online tool available with videos and how-to step sheets, everything you need in this 5-step program for you as a patient, and then they've also built a prepare for their care if you're the caregiver helping support a loved one in making these decisions. To pick your backup person, think and talk about what matters most. Thinking about what kind of decisions would you want your loved one or whoever is your assigned backup person, your friend, whoever it is that you trust to make. And it helps you decide who would be a good person to pick, and alternatively, who would probably not be an ideal person to pick to be your spokesperson. It helps support you in telling others about all of those wishes and formalizing it in the documents you have even for your healthcare team. And it helps tee up the kind of questions that you might not be thinking about that are relevant to what's important to you, that can be translated into an actual advanced directive document, which is a very helpful sort of official formal care plan. Prepare for your care takes you through all those steps and actually, based on your answers, churns out a state-specific legal advanced care directive that you can give to your healthcare team. And in fact, I found a lot of hospitals and health systems actually have the link to prepare for your care on their websites. So they are increasingly recognizing the value of this tool to help people do that care planning ahead of time to save some distress. So I feature here the two different programs, helping you as a patient have a voice in your care, and then prepare for their care, helping other people. Many, many patients from all walks of life and caregivers were involved in developing and testing this content. So it's tried, true, and really, really helpful for people. And I encourage you to just snoop around on the website a bit, because it's just, for me, when my husband was in the ICU facing cardiac surgery, open heart surgery, we walked through this together the day before. The questions were actually very comforting to go through together and served as that scaffolding for the conversation we needed to have and to give to a surgeon. Hugely helpful. My organization, Patient Advocate Foundation, has also produced sort of the prequel set to that, helping people thinking about care planning, writing down what matters to you, identifying your backup person, making that plan and sharing the plan. We developed this actually when COVID started to really take hold across the country as a quick tool for people to pre-plan for should they get COVID and things go very poorly. And I feature the link here. It's a very easy format, just like Prepare for Your Care, that you can fill in online and download to even print. But another place that we have a number of tools are what we call the Can We Talk guides, because can we talk about these various different parts of getting care for people with all sorts of serious illness, talking about what matters to me, talking about what being a caregiver or a care partner is, talking about telehealth and experiencing that, which has become more prominent lately with the COVID pandemic. And also, importantly, talking about the costs of care, because for everybody that faces diagnosis of anything serious, usually financial concerns are part of the swirl of what we worry about, even though they don't typically and customarily reliably get asked about. So these are some tools to help be thinking about the stuff that's on your mind and bringing it to the conversations that you have with family, with friends, and with your healthcare team. There's also a game called Hello, and a short version that you can play online called Hi, which has another way of taking the worry and stress out of talking about dying and translating that into how do I want to live until I die and what's important to me. And I feature one question here, which really is my favorite, and the crux of these slides is, for my healthcare team to provide the best care possible to me, what 3 non-medical facts would I want them to know so that they're treating me and thinking of me as a person as we're working together through decisions about our care? There are wonderful coping tools as well. Get Palliative Care, featured on the right side, is a patient and caregiver facing online resource that describes what palliative care is in people's terms and how you can get it and where you can find it. for both patients and caregivers to use that tool to get more conversant in what this kind of care is and how it can be an extra layer of support for you as you're going through your illness or caring for someone. Archangels has an incredible little online intensity test you can take or share, where people can see, where am I on the spectrum of super stressed about being a caregiver on through, today I'm at peace with this. And just sort of helping self-gauge where you're at can be very helpful so that you can give yourself some grace. And it also provides resources that you can use to help support you in times of high stress, based on sort of the objective data that you deliver to yourself from taking this quiz, and just normalizing the fact that you're not alone. Caregiving can feel very isolating. This tool really helps people to see, I'm not alone. This is a common practice to feel this way, and there are others out there to help. So in the interest of time, I'll skip through very quickly because I know that Jill is going to touch on the importance of palliative care as a key part of quality of life. But I'll just highlight one thing that I have found so immensely helpful about palliative care alongside disease treatment. It helps keep you out of places you don't want to be, like the emergency department, like going back and forth to the hospital or other settings that are just what you're trying to avoid because they tend to your symptoms and what matters to you. So that's a key aspect and asset of this service that I know Jill will talk about in more depth. And I'll close by featuring my mom. Today would have been her birthday. She would have been 86 years old today. And as I took care of her through her ALS, she talked about the importance of palliative care and how they helped game out for her what to expect. And she said, what this does is it helps me stay ahead of the game. There's so much comfort in that. And I'll turn it over to Jill to tell you more of the details about what that means. Thank you.
Thanks, Rebecca. That was wonderful. And thank you also for going ahead and going first. So I'm going to just share my screen here. Can you see that okay?
Yes.
Okay. So I am mostly going to be speaking from palliative care. I do work in amyloidosis, as was mentioned, but I also am a palliative care provider in the community. So I only see end-stage heart failure patients and amyloidosis patients for that second job. And I just wanted to let you know that I don't have any specific disclosures as well. I do work at the University of Utah in the Huntsman Hospital. They're right here connected in Utah, and we have both the oncology and the cardiology patients. This is our team, and I am kind of proud of the team that we work with. We do serve 7 different states in the nearby region, and happy to answer questions about our program if you need that as well. So speaking of palliative care, I'm going to kind of go through these general principles today, really defining what it is, because I think a lot of people have different definitions, talking about how it's different than home health and hospice, and some of the different types of models that you can see out there, and also going to talk a little bit about when may be the time to engage in palliative care or other services when you have cardiac amyloidosis, and does heart failure play into that as well? And then we'll also talk a little bit about conversations to have with your providers as well as with your family members. It's always a difficult topic to bring up in the moment. So first of all, what is palliative care? So there's lots of different definitions. The World Health Organization defines it as an approach that improves quality of life of patients and families who are facing problems associated with life-threatening illness, It prevents and relieves suffering through early identification, correct assessment and treatment of pain, and other problems, whether physical, psychosocial, or spiritual. So I really love that it's all encompassing. They obviously put a lot of thought into it. But when you ask patient and family members what they think palliative care is, most of the time they will associate that with hospice and that they are dying. And if you ask healthcare workers, incidentally, what palliative care means, it usually means we don't have anything else to offer the patient, unless they've been involved in palliative care personally and had multiple experiences with it where they can learn about it. So, sometimes we have to educate as family members and patients, some of the other team members that we work with in the medical field too, and not assume that they all know what palliative care means. So my second job that I was mentioning is 1 day a week. I do home visits for patients who have end-stage heart failure, and my goal is to keep them out of the hospital. And many of them have cardiac amyloidosis, and I will kind of go into that a little bit today. This is an example of a patient who had the transthyretin wild type amyloidosis, as well as monoclonal gammopathy of unclear significance. If you're not familiar with that, that's kind of like the pre-light chain amyloid. Very, very commonly found in wild type patients and very rarely progresses onto light chain. So this woman had end-stage heart failure, and she also had a lot of shortness of breath, fatigue, a lot of bloating and nausea, relentless nausea, back pain, orthostatic hypotension, and she did have a diagnosis of renal artery stenosis, spinal stenosis, severe tricuspid regurgitation. Some of these might be familiar to you. They're often very common in other wild type patients. Her ejection fraction, if you're familiar with that term, the squeeze of her heart, was measured at 45%, which was not significantly low compared to some patients, but not normal. And she was in and out of the hospital several different times. And after about 3 hospitalizations within the same year, we knew that that her chance of coming back to the hospital was going to be more frequent. And she did not like coming back to the hospital. And so we offered her some home milrinone that she was able to have for nearly 2 years, and it allowed her to be able to have home palliative care with home health services. And she was able to travel and go on a cruise with her family and go on family vacations. She did require a lot of family support, but they were willing to provide that. And this was a great option for her because she enjoyed those last years of her life. And we were able to manage her symptoms and help communicate with her other team members what really was the overall big picture of her care. So I will come back to her story again at the end, but I'm going to go through a couple of different types of services that are provided and often needed when you have more chronic illnesses. So home health. Most people are pretty familiar with home health, but just want to review the services that are included are usually things like physical therapy, occupational therapy, speech therapy. You can often have nursing care, a nurse's aide, and it's usually patients who have either been hospitalized and then just discharged, or you can come on out without a hospitalization if there's some kind of skilled need for a set period of time. It doesn't last forever. And is usually billed through Medicare or private insurance if they're younger, and it can be Part A or Part B. So home health is, of course, provided in the home. They need to be certified that they are homebound, except for like doctor's care visits, things like that. And again, it's a temporary thing. Hospice is usually something that is prescribed for a patient when they have been given a diagnosis that they may not be here within the next 6 months. Although hospice can go on sometimes for several years, and you can requalify for hospice because we don't have a crystal ball as medical care providers. It is also billed through Medicare and Medicaid. This is usually through your Part A services. And when you engage in hospice benefits, then you tend to pull back from like clinic visits and other outside providers. But it's not impossible. And if people tell you you can't see other doctors, sometimes they may not have the full information. It just has to be billed very carefully. And so where can hospice care be provided? It can be provided in the home. It can be provided short periods of time inpatient. It can be provided in a skilled facility, also assisted livings, independent living centers. Some people have wondered if this is different than home hospital. I don't know if you've heard of that term before. Here, some hospitals use that as after you have discharged from home, you may go home with remote connections to the hospital. So you may have like a call light from your own home that you can connect to, and then it will call the nurse's station and they will answer questions. And you can have a home health nurse or someone come into the home and answer questions or manage IVs, but it's not obviously as immediate as if you were in the hospital. Not very many models have that, and it is not the same thing. It is different. So what is palliative care then? So the people who qualify for palliative care are different than home health and hospice, and yet the same. So oftentimes, I try to describe this to patients as it's like a bridge. So sometimes you can have standalone palliative care, and you can have palliative care with home health, and you can have palliative care with hospice. And so palliative care is the services provided usually from a medical provider such as a doctor, a nurse practitioner, physician assistant, and also social work. But if you wanted to have the physical therapy, you'd have to have home health with it. Hospice does not have physical therapy. So there's certain things that patients will fit in different categories, and some patients just have palliative care by themselves. So when do we start looking at whether someone would qualify for palliative care? Usually it's when they want to try to avoid frequent hospitalizations. And it's getting more difficult for them to come to the hospital. They maybe have, they're wheelchair bound, have oxygen, they have a lot of equipment they have to bring, they're very sick, they're very short of breath, and it just becomes really difficult. But if they don't see that provider in clinic frequently, then they are often subject to being hospitalized again because nobody's monitoring some of these meds that need to be adjusted carefully, especially diuretics and medications that affect your blood pressure, things like that. And so it is actually a service trying to keep patients out of the hospital, trying to keep them out of the clinic every few weeks, every month, but also keeping them healthy and maintaining where they would like to be. It is also billed just like a normal clinic visit. So it's Medicare Part B. And sometimes it's a little bit higher bill than a clinic visit because the services are longer and there's a lot of care planning that goes into some of those visits, but insurance covers it and they cover it the same as a clinic visit. You can be on palliative care as long as you need. Some people will stop and say, you know, I'm doing better. I'm not having hospitalizations. We've got these meds tuned. I don't need palliative care anymore. But most of the patients I see are on palliative care till end of life, and they will go back and forth with the home health for a while, and then they gradually switch towards hospice or just stay on palliative until they pass. So you've heard of palliative care providers that will come and do consults in the hospital, and they will talk with patients and family members before a major surgery or before some kind of procedure is performed, or if things are getting a little more complicated in their medical history. These palliative care providers can also do visits in clinics. Sometimes after their discharge, they'll continue to follow up and they'll make appointments in the clinic. There will be visits at home, like I was explaining, from someone like me. Virtual visits can be done, but they're a little bit harder. And then home hospital is okay too, but it's a little bit different model that's still emerging. So what are some of the common topics? I think Rebecca discussed a lot of these already, as far as advanced directives. But when we kind of bring up this topic first, we usually start talking about goals of care. And that usually starts out with, what do you want to see your last days look like? And kind of leaving it open so that you can have a discussion and do a lot more listening and learning than teaching and providing. And I loved that Rebecca talked about how it's an ongoing thing, not a one-time conversation, especially with our sick patients with heart failure. So sometimes we'll sit down and one whole visit will be just filling out the pulse, the physician strategy to, decide if you want to have CPR, things like that. But other times are there specialized needs? I saw there was a comment about cultural references, and that can be a specialized need. There was also a question about resources for patients with disabilities. I know that some patients, we've had to give them resources in the community where they could widen their doorways in their homes so that they could fit their wheelchair through there. There's others who have a woman I visit who is very deaf, and she is having some services put in her home so that the light flashes when her doorbell rings. And so there are those services available, and that takes time to figure that out. And oftentimes people in home health don't know all of those answers. Social workers are wonderful though, and they are a huge part of the palliative care team too. Again, trying to prevent admissions to the hospital, and then a lot of teaching. A lot of patients would like to know, where am I going? What am I going to feel? What is going to happen as I get closer to death? And so we'll talk about things like stages of dying. So just as if you've ever had a baby before, they talk about stages of birth, and you have to go through these certain stages. Some people, when they deliver, go through those stages really fast and they have a rapid delivery. Well, sometimes that's the same with stages of dying. And, obviously, if there's direct insult to the heart, that could be very immediate. But if it's not, then sometimes you have to have certain things that happen. And we can sometimes see those stages within weeks and within days. And we don't have a crystal ball, but it's nice when you have had experience like that you can help patients to see and to gather people. Patients also want to know their prognosis. They want to know, do I have years? Do I have months? And that's hard because we're not great at that. And it's not our role to provide that, but we can say things like, studies show that if you've been admitted to the hospital for heart failure for three times within one current given year, you're not as likely to be around next year as somebody else who hasn't. And so there's biomarkers that we can look at. There's things that we can say patients that have an NT-proBNP this high are not as likely to be around within the next year. And so that can kind of give patients some guidelines. Or we can say, you know what, your biomarkers, everything looks so great. I know you think that you're not going to be around here, and I know you don't feel great, but you could be here for years. And so you need to plan ahead. You need to make sure you have the support to maintain this chronic illness. There are different causes of death in cardiac amyloidosis. The most common one is called PEA, pulseless electrical activity. It's a type of arrest where you look like on an EKG you have a rhythm, but really there's no pulse. And there's other arrhythmias such as ventricular tachycardia or heart block. If someone were to die suddenly, then sometimes that's a very peaceful way to go. But it doesn't always happen that way. A lot of patients will have heart failure exacerbations and be, in this cycle of readmission to the hospital versus staying at home. And we have to pick medications that will keep them comfortable. And so we have this conversation sometimes that we say, we've always been playing this dance between the heart and the kidneys. But if we get to the point, at some point down the road, we're not going to do that yet, but right now, I want you to know that if we get to that point, we always pick the heart. And we pick the heart because when your heart is struggling, you're short of breath and you're symptomatic. But when the kidneys are struggling, then when you go into renal failure, you just stop urinating, you get sleepy, and you just fall asleep. So if we have to get to that point where we pick, then we push the diuretics. And we push the diuretics and we keep you so you don't have to be at home. We keep you comfortable. And it's a process and it's difficult, but we kind of help patients to understand that we're going to be there for you. We're going to help you with this symptom management. And then, of course, there's patients that maybe are struggling all along, but then there's other things that will come up, such as an infection or a fall that we call like a sentinel event. So I kind of talked about some of the qualifications before, but things like if you're on an inotrope like milrinone that helps support and increase your cardiac output. If you have a very low cardiac output and you're older, so you're not a candidate for like a heart transplant or an LVAD, sometimes that's also a reason. If you've had significant hospitalizations over and over and over and there's really no improvement. Other comorbidities making it hard to come to clinic regularly. If you have another terminal diagnosis that's contributing to this, and if the therapies are not working. But age is not a determinant. We don't just say just because you're older, you can be on palliative care. But a lot of these things, of course, happen with older adults as well. I do think that there's not one specific time to bring up palliative care. I do like the idea of bringing up palliative care early on, maybe not in the very first visit when someone is diagnosed, but some of our patients with light chain amyloidosis, after they've started to improve and chemotherapy is working, then maybe we also just kind of step aside for a second and say, we're just going to have this goals of care conversation. Has nothing to do with your prognosis right now, but we want you, because this is a life change and you're thinking about things right now, to kind of meet with these people and talk with them and decide what you'd like your last days to look like. And if they're not ready for that, then we back off and that's okay. Some people aren't ready for that. But if you have an ideal situation, I think it's do it early and do it before. If you've had several hospitalizations in a row, sometimes when we're screening patients for transplant, we need to know. We need to see what kinds of things they would be willing to go through. Sometimes we also just can see that they're getting sicker and they don't know how to quantify that. So in clinic, we'll just talk with them and we'll say, have you ever talked about with your family members what your last days would look like? And, if they're really curious and would like to know more, then it's time for a consult. And sometimes if the patient is not any safe at home anymore, then we need some extra services and someone to investigate how we can help support them. I'm going to not bring up how to bring up the conversations because I think Rebecca kind of covered this too, but I liked her cues that she talked about, but environment and timing really matters, and you really need to have family members there. If family members can be there even virtually, that's okay. But in person, the provider and the patient should be together. That should not be done virtually. And it's okay to record these things so that you can come back later and say, well, this is really what mom said she wanted, instead of people remembering different things. And a lot of documentation. So to go back to my patient from the beginning, as she was at home, she had some questions. She wondered at some point, she said, if I turn off this milrinone, is that actually a form of assisted suicide? And I had to explain to her that it was not, and that it was different than life support. It's a medication that was, and it's okay to make that decision to say, I don't want this anymore. I've been suffering enough. And I actually told her, I said, you know, a lot of patients become tolerant to milrinone after a while. And so, especially if their ejection fraction's low, then they often will pass pretty shortly after that milrinone is stopped. It took her, I think, about a couple of weeks, but I said, you know, you could pick the time of year you wanted. You could say, I want my family, you know, to be here at this springtime or whenever, and to remember me. And she actually did that. She had a big dinner and she invited all of her family, and then she decided when she wanted to turn off her milrinone. We don't have a crystal ball. It is different for everyone. But we do try to help them kind of see the progression in a gentle way. So she asked about her pacemaker. She said, do I need to have my pacemaker turned off? And that's a valid question. It's not the same thing as a defibrillator. Obviously, a defibrillator we would want to turn off. We didn't turn off her pacemaker, and that was okay. Usually when your body becomes more acidic, then the heart will override the pacemaker anyway, and you'll go into an arrhythmia or something else anyway. What symptoms will I experience? So that was important to reassure her that, you know, that we can give oxygen, and we will continue to make sure that she doesn't have pain and that she doesn't have air hunger. And to let her know that I would be there with her through the end, as well as her hospice team. And then I had questions for her too. Was there anything else you want to finish before you pass? And she decided she wanted to write some letters to her family. That was important to her. And she decided, as I mentioned, she wanted to gather her family around, which she did. So in summary, palliative care is not well known to the community. There's many definitions of it, and different models. And I think a lot more education is still needed. I think especially funding is important. I think you would probably see more home palliative models if there was better funding. Palliative care does save Medicare and Medicaid money, though, because especially in this patient population in heart failure and amyloidosis, it prevents hospitalizations and readmissions. Palliative care discussions also save other healthcare providers time, which is so important in these busy medical communities. Usually, stages 3 and 4 of cardiac amyloidosis will qualify for palliative care services, even if they don't have a diagnosis of 6 months. Patients, families, and home health and hospice companies love working with palliative care providers. It really eases their burdens. And discussing health, death in a healthy, open, and honest way really does lead to better outcomes. So with that, I'm happy to take any more discussion or questions.
Thank you so much, Jill and Rebecca. And this was an amazing talk, subject that's often hard for people to talk about and discuss, something we hear a lot from patients who want to know these things and ask questions. So it really was wonderful to hear this talk. I did particularly like Rebecca's comment that nobody is at their best when they're feeling at their worst, because I think that's so true, and the importance of planning and hearing, you know, Jill, how remarkable the services that you provide are, and the relationships that you build with patients can be so meaningful, and I think building those relationships are critical to good care. I know we have just a few minutes for questions, and there was an interesting question about, and we see this with a lot of amyloidosis patients that have multiple different physicians caring for them, for example, a cardiologist and an oncologist. And how does that work with palliative care, and who's kind of takes the lead? And could you talk a little about that, Jill?
Yeah, so in amyloidosis, it's a little easier for our center because a lot of people don't know about amyloid, and so they're happy to let us take the lead. And so, we will help them know this patient's fine to go to surgery. Don't worry, we'll help take care of their heart while they have back surgery, whatever. But if it's something more like our light chain patients or our multiple myeloma patients, and someone's pushing and pushing and pushing, and that's fine if the therapy's working, but sometimes I've had to email their oncologist and say, your perspective may be different than ours, but I want you to know that this patient's heart is very, very sick. And, we'll play second string to you, but please look at the big picture, because I think they've been through a lot. And sometimes that helps them to back off a little.
And you mentioned some interesting adaptations that can be made to a house for people with disabilities. Is that covered typically by Medicare, or how does that, so is that privately covered, or how does that work?
It's usually privately, but there are some grants here locally, and I'm sure in other states as well, of companies that will provide money to fund projects such as, fixing a bathtub so that they don't have to step to go inside, things like that. But it is a problem. There's not enough money to pay for a lot of those things, but the resources are there, the ideas are there. It's just the funding that's the hard part.
And if you're in palliative care, can you still receive your medication, such as Vindamax, if you were taking that for amyloidosis?
Absolutely. And the tricky part is that most patients get Vindamax through patient, at least here, get their Vindamax through patient assistance for free. So you have to keep that going, but you can still see your amyloid team and have a palliative provider come see you at home. So you could go there maybe once a year, just enough so that they can help you renew that. But then it's just stay at home so that you don't have to leave as often.
And somebody mentioned, and I know we've had this a number of times, been approached with, that if you're considering donating your body to science, how can you go about that?
So it's an interesting question, because I am actually working with 3 patients right now who are hereditary, wild type, and light chain that all want to do that as well. I will let you know that you have to have the documentation done ahead of time prior to passing. And also, I've learned that to get samples from amyloid, you have to procure those before the patient passes. Sorry, not passes, is embalmed, or because that will change the tissue. And so the timing is also important of where you're at. And then the biggest obstacle is funding. So, if there is not somebody who wants to invest in a specific project, then they're not going to have a pathologist take all of these samples and use their body for donation. But my suggestion would be that if you're super interested in that you contact the Mayo Clinic, because I have talked with some researchers there who are interested in body donation.
Thank you. And we will share, we also have some resources that we can share. There were some wonderful resources, and Rebecca's, yours were really fabulous that you've shared, I know, having gone on the site and looked at them. So we'll be sharing those around. For anybody who's attended this webinar, we will send an email out with the links to those. this talk, there's also been some questions that people wanted more time to digest this talk, and it will be posted on our website. And so we will share that link as well. And I know at the top of the hour, and I would just thought I would just read one comment, which was from a patient who's also a nurse. I'm a retired hospice nurse with wild type. Over the years, I've cared for many patients with chronic heart failure, congestive heart failure. Their care revolved around going in and out of hospital. I've had the conversation with my cardiologist. I don't want to spend my time or energy in and out of the hospital. He has agreed when I tell him I want hospice, he will place an order for it. I'm very happy with this decision. I think that's impressive to hear, both from somebody who has treated patients and as a patient themselves, to be able to, and the kind of advice to take from that, to really have those discussions ahead of time and plan with your care team. And so thank you so much for this talk. I think it was really very powerful and provides really good information. And I'll just finish by saying one thing that I've heard several times from doctors, that often what's worrying a patient most is not what's worrying them. And so sharing your worries with your care team and discussing these things can be really comforting and alleviate a big burden that patients carry with them. So thank you both so much for joining us today. And if you've attended, you'll receive a link to a survey to fill in, and please fill that in to help us improve and build out our Art to Its program. Thank you so much.
Thank you.